Hello, everyone, and welcome to today's webinar. My name is Olga Bodie, and I'm a SYNGAP parent and part of the team here at SYNGAP Research Fund. Our presentation today is Catatonia and Neurodevelopmental Conditions like SYNGAP1. I have the pleasure to introduce today's speaker, Dr. Joshua Ryan Smith. Dr. Smith is an assistant professor of psychiatry and behavioral sciences at Vanderbilt University Medical Center and the Vanderbilt Kennedy Center. He is a graduate of the University of Mississippi School of Medicine, and he pursued clinical training in adult psychiatry at the University of Virginia and child and adolescent psychiatry at Harvard Medical School, McLean Hospital, and Massachusetts General Hospital. During his training, Dr. Smith obtained, subspecialty training in consult liaison psychiatry, neuromodulation, and autism spectrum disorders at the Massachusetts General Hospital Bressler Program for Autism Spectrum Disorders and Lurie Center. In 2021, he joined the faculty at Vanderbilt to grow and develop clinical and research services in child psychiatry and autism spectrum disorders. Dr. Smith's primary research interest is in bridging the gap between clinical trial research and clinical care. His specific areas of interest include use of transcranial magnetic stimulation in autism, catatonia in neurodevelopmental disorders, consult liaison psychiatry in children's hospitals, and electroconvulsive therapy. Dr. Smith serves as an ad hoc reviewer for many well-known medical journals. A recorded version of this webinar will be available on the SRF website under webinars on the family menu. By the end of this presentation, you will have the opportunity to get to answer your questions. We'd love to hear from you, so please write your questions in the Q&A below. For those of you just joining us, welcome. And again, our speaker is Dr. Joshua Ryan Smith, and his presentation today is Catatonia in Neurodevelopmental Conditions like SYNGAP1. It's now my pleasure to turn things over to Dr. Smith.
Thank you, Olga, for that really very kind introduction. I'm going to try to share my screen, which is always a dicey move. So give me 1 second. All right. So thank you again. My name is Joshua Smith. I'm a professor of psychiatry and behavioral sciences. I am in the division of child and adolescent psychiatry, but I see folks from all across the life cycle. I see our youngest patient we have in clinic is 4. Our oldest one is 31. So I kind of think of myself as sort of a life cycle psychiatrist. So here are my disclosures. My clinic is called the MIND Clinic, and we have 3 industry-sponsored clinical trials, Biorosa, Roche, and Axial. All of them are looking at improving symptoms of autism, and I receive no direct funding or salary support from those. They mostly keep the lights on. So our learning objectives for today, we're going to review autism and this new sort of terminology, profound autism. And the reason I'm doing that is that I think it's really important for us to have some vocabulary, particularly as we're talking about SYNGAP and symptoms associated with SYNGAP. We're going to discuss catatonia as a diagnosis and treatment in autism and other neurodevelopmental conditions. We'll talk about the current research as well as the research that we're doing in our lab. We're going to explore possible connections between catatonia and SYNGAP1 and discuss future directions and opportunities. And I want to put the caveat too that I have a video and a few slides of a young man who has hyperactive catatonia from Phelan-McDermott syndrome, which is another genetic abnormality that's associated with hyperactive catatonia and autism. And the video is, I think it's really important. I think it's a good educational opportunity, and his family has given me the permission to use it. But I'm afraid it could be potentially triggering to some family members or parents who have had kids with similar symptoms. And so I wanted you to be aware, and I'll give plenty of warning before I start it. So let's talk a little bit about autism, intellectual disability, and really disparity. So you guys may or may not be aware, but the Lancet Commission for Autism was released in 2021 by Catherine Lord and colleagues, and she introduced this term profound autism to the literature. There's been some, debate about whether this term is appropriate or sort of the utility of it. But really, I do think it's helpful in terms of easily communicating how severe symptoms are for somebody who meets criteria for autism. So let's go over the requirements for that diagnosis or the criteria. So it needs to be somebody over the age of 8 who has one of these, meets one of these criteria. So requiring 24-hour access to an adult who can care for them likely for the rest of their lives, being unable to live completely alone, not being able to tend to basic daily adaptive needs, having an IQ less than 50, or having limited verbal ability. And again, I'm going to use this term pretty regularly today. So comorbid intellectual disability and autism is the CDC just released in the past month a report of the prevalence of profound autism after the term was introduced. And they think that it's about 24% of people with autism would meet criteria for profound autism. This data I'm giving you is a little bit dated in terms of comparing it to that. But basically, there's speculation that intellectual disability is present in about 30 to 50% of autistic individuals. And it's more often associated with autism for folks that also have comorbid genetic abnormalities. And it only makes up 5 to 6% of autism clinical research, which is always wild to me. And it looks like inclusion is actually worsening over time. And I know I'm kind of preaching to the choir a little bit, if you'll forgive the metaphor, but the systematic exclusion of folks with genetic abnormalities, significant sort of symptoms, limited verbal ability, I think really does lessen our understanding of autism broadly across the spectrum. And it also leaves our most vulnerable folks without significant clinical research to assist with their symptoms and improve their quality of life. And so with profound autism, there's an increased risk for externalizing behaviors, particularly aggression. And there's also a risk of medical and psychiatric hospitalization. And that's in areas that have the ability to hospitalize these folks. A lot of places, including Tennessee, where I am, there's not a designated hospital for folks with this particular sort of symptom profile. The closest one is actually in Atlanta. It's called Laurel Heights. And so if we have people come in and they absolutely need hospitalization for behavior secondary to profound autism, we oftentimes have to transport them there. So let's talk a little bit about aggression and irritability in neurodevelopmental disorders. Oftentimes, aggression and irritability is attributed to behavioral issues. Someone's attention seeking, someone is trying to get something out of their behaviors. And when that happens, it sometimes clouds our vision around, is there something identifiable and treatable that's causing the aggression that we may be able to identify and treat? And it also leaves us not categorizing subtypes of aggression. So there's different kinds of aggression. There's aggression that is self-injurious. There's aggression that's injury to others. There is aggression that seems to be targeted. There's aggression that's not targeted. And identifying those and separating them out is really important because it allows us to say, hey, this is more likely X, Y, or Z that we may be able to treat. And then catatonia is an area of particular interest to me clinically and from a research perspective, because it is something that results in aggression and irritability in neurodevelopmental disorders, but it's treatable, identifiable, and relatively rapid in response to treatment. And we're going to talk a little bit more about that. So what is catatonia? Catatonia is, this is a little bit jargony, so I'm going to say it and then we'll break it down. It's a psychomotor syndrome with affective domains and distinct physical examination findings. And what that means is that when I say psychomotor, I mean that people either have really increased amounts of motor activity or really suppressed amounts of motor activity. And affective domains, is indicative of changes in one's mood sort of rapidly in responses to stressors or not. And classically, this has been identified in schizophrenia, affective disorders, meaning bipolar or bipolar depression or mania, as well as major depressive disorder or medical illness. And typically when people think of catatonia, they think of the stuporous iteration of catatonia. And we'll talk about that a little bit in a minute. But the stuporous iteration of catatonia is when someone has posturing, where they're unable to move their arms, or they're unable to follow commands, they don't eat or drink, and they have periods of staring where they can't, it seems like they can't move their eyes to be able to identify who's in the room with them or trying to speak to them. And that does happen in neurodevelopmental conditions. You can certainly have the stuporous iteration of catatonia. But a really pivotal paper in 2020 by Vicchierzo Serrano and colleagues found that 20.2% of autistic individuals have some degree of catatonic symptomatology they've experienced over the course of their life, and 10% of autistic individuals may meet full criteria for catatonia. And what's interesting about that is that people with autism, and as we're learning more, autism and additional neurodevelopmental disorders, are more likely to have a hyperactive version of catatonia rather than a stuporous iteration of catatonia. So what Viqueiros Serrano found in his paper is that the most common symptoms of catatonia and autism were a loss of previously acquired verbal skills, a lack of cooperation or negativism that, to my mind, as a clinician, could oftentimes be attributed to oppositionality or attention-seeking behavior, and then agitation and aggression. So there's two versions. Again, there's the hyperactive version, extreme agitation. It's less often diagnosed, and it's perhaps more common in autism and other neurodevelopmental conditions. And there's the stuporous iteration, which is generally considered the classical version. And then from a psychomotor perspective, some have actually characterized catatonia as similar to Parkinsonism, not in that it's neurodegenerative, but in that in Parkinson's, you can have both symptoms of extreme motor activity, hypermotor activity, and also stuporous activity. And I think it's important to mention here, and we'll reiterate it again, is that catatonia is a lot like fever. Catatonia always comes from something else, and it's a symptom that we're able to treat in the same way that you would give ibuprofen to lower fever. You can treat catatonia in a similar sort of way. But what causes catatonia would be, again, sort of like classically, we think of schizophrenia, we think of mood disorders, medical conditions, but what we're finding out is that autism and then other genetic conditions can be the sort of underlying cause of catatonia, particularly when stress is involved. So what does this have to do with SYNGAP1? So for SYNGAP1, looking at the literature myself, is there's a lot of characterization of challenging behaviors in SYNGAP1. And if you really break it down, the challenging behaviors line up considerably with catatonia. So affective instability, oppositionality or negativism, ataxia, which you can also see in catatonia, and then recurrent self-injury and aggression. And while there have been reports investigating catatonia and other neurodevelopmental conditions, there are no reports in the literature looking at does catatonia occur in SYNGAP? And we'll talk a little bit more about that in a moment. But by the end of this, I'm hoping to convince you that this may be something that occurs in SYNGAP that we're able to identify and treat. So this is the video that I was referencing. I'm going to try to see if I can get it to play. And again, I want to just caution anyone that this may be somewhat distressing for folks to watch. But I also want you to know too, I'm going to go ahead and skip a slide, that this young man, his name is Lucas, is doing much better. This is Lucas and I. He's walking in to actually get ECT. He's doing much, much, much better, has had a really positive outcome. So I want to make sure that I've sort of introduced that before I show you this video of some more challenging symptoms. So you hear him kind of making these vocalizing sounds that sound distressed. And in catatonia work, we call this vergibration, where it's the production of sort of nonsensical sounds, oftentimes in a repetitive manner, which can be distressing. And you can see that he's moving chairs around. This is, again, sort of like in catatonia, we call this manneristic behaviors. I always tell the trainees that mannerisms are anything that you see someone doing and you're like, why are you doing that? It seems very odd. And he certainly has that. And mannerisms can progress to where they are aggressive in nature or self-injurious.
Hey, Lucas, Lukey, Luke.
So I want to take a moment here to show you that he is posturing, right? So when I was describing the more stuporous version of catatonia, we were talking about the fact that posturing occurs. Posturing occurs in hyperactive catatonia as well. So you can see that he takes a brief minute, maybe even less than a minute for this posture.
Lucas.
And he's also having some diminished eye contact from his baseline. When you're treating folks with neurodevelopmental conditions with catatonia, it's key to know their baseline, to collaborate with families, and to make sure that you understand where families are hoping that their child or their ward will get back to, what symptoms you're hoping that will improve.
Hey, bud, what's wrong? Waiter.
He's posturing there again. And he's also having this kind of, families often describe it as this look of knowing that aggression is about to come. So he's about to have an aggressive episode. The family member filming this was not harmed.
You want to watch a movie? You want to watch Paw Patrol? You want to watch Paw Patrol? Hey, make him watch Paw Patrol?
And so again, I know that can be a distressing video to watch. It's honestly distressing for me to watch. But he's doing much, much better now, has responded beautifully to treatment. That is me, for what it's worth, next to Lucas. So the symptoms of catatonia are wide-ranging, and I think that's important to acknowledge, because a lot of times I'll start introducing catatonic symptoms to families, and they're like, well, this is a lot of symptoms that you're describing. And it's true. And in fact, there's actually a lot of symptom crossover between catatonia and autism and other neurodevelopmental conditions. And so when we're looking at this is an excellent graph that's from this paper, Structural and Neural Mechanisms of Catatonia by Sebastian Walther, and Dr. Heckers, who's our chair here at Vanderbilt, is the senior author on this paper. There's increased psychomotor activity, agitation, excitement, impulsivity, combativeness, and then decreased stupor, ambitendency, which is where folks are stuck in a movement. So they're sort of repeating the movement over and over again. Or another great example, there's an excellent book, if anyone's interested in reading further, called Autistic Breakdown. It's written by Dr. Shaw in the UK. She describes about 20 or 30 cases of catatonia in autism. And she often describes ambitendency as being stuck, sort of entering a room or crossing a threshold. And then vertebration, we've discussed echopraxia and echolalia. Echopraxia is repeated movements, like observing somebody and then having the movement occur. And then echolalia is repetition of a word that's spoken. Automatic obedience is an inability to appreciate the not in a command. So oftentimes I'll tell folks I'm assessing, shake my hand, they'll shake it, and I'll say, please do not shake my hand, and they'll continue to shake it despite my sort of, I'm sorry, I'm having a difficult time with my mouse here, despite my efforts to get them to not do that. And then there are other terminology. Mitgehen and Gegenhalten are German terms that are carried over from when catatonia was first described in Germany in the 1800s. Gegenhalten is when you can lightly, or Gegenhalten is also called paratonia. It's when you get equal and opposite resistance in terms of like looking at someone's muscular pressure as you're pushing against their arm. And then Gegenhalten is actually folks will have a light tap of their arm and they'll drift it in the air like this and then continue to hold it. And then grasp reflex is not what we traditionally think of grasp reflex. So grasp reflex in sort of like neonatal science is that you rub the inside of a baby's hand and they will hold your thumb as you rub it. This grasp reflex is reaching out for everything nearby and trying to grab it. So there's a lot of diagnostic scales we use in catatonia work. There's the Bush-Francis Catatonia Rating Scale, which is far and away the most often utilized. It is validated in neurotypical folks with psychiatric conditions, but it's lacking in pediatric and neurodevelopmental data. There's also the Pediatric Catatonia Rating Scale, which is 20 questions, 14 actually are from the Bush-Francis itself, and then 6 additional symptoms, excuse me. And this was put together by Dr. Cohen and colleagues in France, and they do outstanding research. And I'll actually show you one of their papers here in a moment. But they also identified acrocyanosis, which is really cold extremities, schizophasia, which is basically sort of like the production of garbled speech, and then automatic compulsive movements. And the scale that we use most commonly is the Kanner Catatonia Rating Scale. So it includes a severity measure and an examination. It's more precise, but it still misses some specific pediatric symptoms. So I'll just generally ask about those. It's not validated, but it is designed for neurodevelopmental disorders. And so on our service, we will treat, I have an outpatient clinic where I see folks with catatonia, but I also see a lot of catatonia at the Children's Hospital here. And what we do is we end up using a combination of the Bush-Francis and the Kanner Catatonia Rating Scale And by using a combination of those, we oftentimes will catch everything we need to. So just some more kind of highlights about catatonia. It's more prevalent in biologically male individuals. If it's pediatric in onset, it usually occurs around puberty. The DSM-5, you only need 3 of the 12 symptoms to make the diagnosis. And that's really to sort of encourage clinicians to think about catatonia when symptoms are occurring. And then regressive symptoms are more common in children. And that'll also include in just folks with any neurodevelopmental condition. When I say regressive symptoms, I mean loss of a previously acquired skill, urinary incontinence, social withdrawal, and reduced eating and drinking. And then again, more externalizing behaviors like aggression and self-injury. And it comes from something, so it's similar to fever, and it's likely due to, this is a little jargony, but I'll circle back on it. So it's likely due to dysfunctional GABAergic and dopaminergic signaling, and what that means is that it's likely secondary to the brain being too excitable, too hyperexcitable and potentially hyperplastic, and we'll talk about how that likely pertains to SYNGAP1 shortly. And it's also very likely that symptoms of catatonia may be worsened by antipsychotics. I wish I had a nickel for every family that's told me that their child's symptoms were worsened by antipsychotics. So they were started on risperidone or piprazole or something like that, and the aggression actually worsened. And that's always something for me that raises a red flag. So we've talked about this, but just to reiterate, catatonia, known psychiatric causes, major depressive disorder, bipolar, schizophrenia, delirium can also cause catatonia, and I'm happy to discuss that in more detail if anyone's interested. And then neurodevelopmental conditions, it's been described in autism, Phelan-McDermott syndrome like Lucas that we saw previously, trisomy 21, Prader-Willi, juvenile Huntington's, and others. So there's infectious causes as well. There's meningitis. You can also get electrolyte derangements, meaning like low levels of sodium, low levels of potassium, encephalitis, infectious encephalitis, but also autoimmune, and then status epilepticus. Seizures can actually precipitate catatonia as well, which is certainly something to be concerned about in SYNGAP, given the really high prevalence of early onset epilepsy. Neuroleptic malignant syndrome is a very hotly contested topic in psychiatric literature. There's a lot of people that say that neuroleptic malignant syndrome is a worsening of catatonia if you give someone an antipsychotic, but we have described it. It looks a lot like catatonia, and the treatment is the same, and it happens after receiving an antipsychotic. So this is a fantastic paper by Scott Beach and colleagues, came out in 2017, and it is the far and away the most robust review of treatment of catatonia. And this is, again, for neurotypical folks with psychiatric conditions or medical illness. And it's for adults. So this paper looks at adults. So you start with IV lorazepam, IV Ativan. You give something called an Ativan challenge. So in an ideal universe, we would see someone with catatonia, likely in a hospital setting. We would treat them with Ativan, about 2 milligrams IV. And then literally within about 10 to 15 minutes, we would see symptom improvement. And that's actually our diagnostic criteria, which is, are they responding to Ativan? Is it improving their symptoms in a 10 to 15 minute time frame? And if it does, then you have your diagnosis, you know it's catatonia, you know what to do next. And neurodevelopmental work, this is more complicated, and we'll talk about that in a moment. And then ECT is usually the next treatment because catatonia can be really debilitating and sometimes life-threatening. ECT is, I'm also an ECT provider at Vanderbilt, and I'm a big proponent of ECT. ECT is heavily legislated, particularly in Tennessee and in California, and we'll talk about that in a minute as well. And so it's hard to get treatment for children, and it can be hard to get treatment for adults that need someone to consent for them. And then a glutamate antagonist, which is either memantine or amantadine, and then anti-seizure medications, and then antipsychotics. And what I end up doing is I go here. So I start with a benzodiazepine. I oftentimes will use a longer acting benzodiazepine because we've had more success using longer acting benzodiazepines like diazepam or clonazepam relative to lorazepam. And then I will move to glutamate antagonist. Memantine is a medication I use really frequently. The trainees here actually tease me about how often I use it, but it's very safe. It's also used off-label for irritability and autism, and off-label for ADHD. The side effect profile is generally just GI distress. There's also a slightly elevated risk of seizure, but if I'm also giving somebody a benzodiazepine, my concern for precipitating a seizure is lower. And then antiepileptics from there. Valproic acid is the one with the most amount of evidence. Valproic acid, we always need to be cautious with using it for anyone that has a uterus because it's a teratogen, meaning that if there's a fetus, it can be really devastating to the fetus. And I would say too, I have to get a long way before I consider doing antipsychotics. And the reason being is that a lot of the folks that I work with, they're exquisitely sensitive to antipsychotics. And a lot of that is because I think we don't really understand the connection between catatonia and neurodevelopmental disorders well enough to say these three antipsychotics, which have good evidence for their use in adult neurotypical folks with catatonia, that it will definitively work. If I go for them, I'll usually use low potency antipsychotics, quetiapine, olanzapine. Clozapine is the one that has the best evidence for treatment of catatonia, but that's a whole nother sort of issue because you have to get weekly blood draws to get clozapine because it can suppress white blood cell activity and potentially cause infection. The risk of that is really low, but that's sort of the system that we're in. And unfortunately, I think it's underprescribed because of that. And I don't really know if weekly blood draws are absolutely necessary for that, but that's the situation that we have there. So we talked about this a little bit. We classically use the lorazepam challenge to diagnose catatonia, 1 to 2 milligrams of IV lorazepam. Dosing is typically 3 to 4 times a day. IV formulation is most often utilized, particularly in the hospital. And reduced oral intake is a hallmark symptom of catatonia. So you really need to use IV in particularly cases where that's a primary symptom. And then you need to escalate doses quickly to avoid malignant catatonia, which we'll talk about in a moment. And then transitioning to oral in about 2 days. So again, that's a very idealized version of what can happen in catatonia. In autistic catatonia and in catatonia with other neurodevelopmental conditions, we have found in our clinic, and I'm going to show you guys some pretty significant data on this, is that the longer acting medications tend to work better for children and for folks with neurodevelopmental conditions, particularly autism or symptoms of autism. And part of that, we believe, is that autism, based on a lot of the neuroimaging research and as well as TMS research, which tests for and probes for how hyperactive the cortex is, has shown that the cortex is likely hyperplastic. And what that means is that the cortex, the brain of somebody with autism, rapidly acclimates to whatever you introduce to the system. So if you give someone a short-acting medication like lorazepam, they may not have the response you would expect a neurotypical person to. And so our hypothesis is that we need higher doses of longer-acting benzodiazepines to get similar sorts of success in terms of treating catatonia for folks with autism and neurodevelopmental conditions. And again, I'll share that data with you shortly. So if you'll forgive me my soapbox for a minute, ECT is a very safe and often life-saving intervention. We released a paper in the Journal of Autism and Developmental Disorders here, where we did a 10-year retrospective analysis of everybody with autism, with or without intellectual disability, who received ECT. About 90 to 95% of folks had statistically significant clinical improvements in a myriad of different symptoms: psychosis, catatonia, irritability, aggression. It's really effective, and it can be a life-saving treatment. I mentioned malignant catatonia earlier. Malignant catatonia is something we are concerned about. It's when catatonia results in vital sign changes. So elevated heart rate, elevated blood pressure. And when that's happening, we really need to look at using ECT, because if malignant catatonia goes untreated, it has a mortality rate of about 10 to 20%, again, in neurotypical populations, but it can be a medical emergency. And Tennessee and California are 2 of the most restrictive states for ECT care. So in Tennessee, anyone under the age of 14, you have to have 2 psychiatrists agree that ECT is indicated. One of them cannot charge for the consultations, so they can't stand to gain anything financially. Then you have to have a group of 7 people from different specialties agree that ECT is indicated. Then you have to go before a judge. And generally, the state of Tennessee will assign the child a guardian ad litem, will assign, there'll be legal representation from the hospital, And then the state will have their own lawyer, and the three of them come as well as the family, generally because the child is not able to come, or the patient, and the judge will sign off. I've done this a few times. I've never had a judge say no. And there is a caveat in the Tennessee laws around ECT that say if there's absolutely emergency, you can go ahead and do it. But what's tricky is that if someone comes into the hospital and they have malignant catatonia, I'm going to treat them with really large dose benzodiazepines, maybe even have them in the ICU on an infusion of benzodiazepines. And so it becomes a question of what is an emergency. So if you stabilize somebody with benzodiazepines in the ICU, is it still an emergency? And legally at that point, it's probably not, because it has to be an absolute life-threatening situation. California is even more restrictive. So anyone under the age of 16 usually just can't get ECT. And it's been so significant enough that folks have had to be transported out of California to either Utah or Nevada to receive treatment. And this is a great paper that outlines some of the state restrictions, if you're interested there. And so this is a quick case of a child that we took care of with childhood onset schizophrenia. She presented with catatonic symptoms. There was a delay due to the ECT legislation where we had to arrange everything to go before a judge. And these are days, these little ticks here. And essentially the child did not eat for this many days until they were able to receive ECT treatment here. And if we were able to start earlier, the morbidity would have likely been reduced. So again, memantine and amantadine, really safe medications, robust safety profile in adults and children. Memantine will use doses of 20 milligrams to 40 milligrams a day. Memantine can go as high as 400 milligrams daily. And as I said, there's a slight risk of seizures. Memantine is cleaner, meaning it is less sort of receptor profiles and whatnot. And it has a lower risk of seizures relative to amantadine. And then we talked about the antipsychotic medications already. So what happens if we treat quickly? Ideally, we're able to confirm the diagnosis of catatonia and have people improve. And sooner is better, because catatonia acts a whole lot like seizures. And you all may know that like seizures that go untreated are more likely to happen again, more likely to be more severe. And so I'm a big proponent of trying to be as aggressive with the treatment as we possibly can until resolution of symptoms. And oftentimes that means having really high dose benzodiazepines. And this requires a degree of trust, certainly with the family, the patient's family, sometimes the patient, around, look, we're doing really high dose benzodiazepines. That means that we need to be really careful about sedation. So if sedation starts happening, that means that our dose is too high, and just doing a lot of education around that with families. And then, the risk of going untreated would be poor oral intake, failure to thrive, potential for refeeding syndrome, and then malignant catatonia as well. And I want to reiterate too, it's really important to identify if there's an underlying cause and if that cause is treatable. So I've already said that autism, genetic conditions can cause catatonia, but also too, folks with autism and genetic conditions can get medical illnesses which cause catatonia. And so we need to make sure there's no sort of symptoms that are happening that we may think are medical conditions causing the catatonia, even if we can say, okay, it's autism, or, it's Phelan-McDermott syndrome. And so we think it's from that. We need to still make sure they don't have, a fever or encephalitis or other sort of metabolic changes. And so oftentimes we'll get an EEG, get labs. And if there's concern for autoimmune encephalitis, Vanderbilt Children's Hospital has a great clinical pathway that you can access with this QR code. But really, we need more research. So what's next and what are we seeing? So I'm excited to show you some of our data, but I will say that we don't have data for this yet, but the report from all over the country and the world is that there's rising rates of catatonia. And we really don't know why. We think that it's probably improved identification. We're using better scales, we're more aware of it. But also too, there's a question of, is COVID contributing? COVID's a neuroinflammatory virus. When people got that, did they increase their risk for catatonia, or did they go ahead and have catatonia if they were potentially going to have it later in life? We really don't know. As well as sort of the stress that catatonia put on us socially in terms of isolation. There's a lot to learn and uncover there. So I'm excited to share some of our data with you. So this is from our clinic. So again, the MIN clinic is we have a clinical trial arm, and then we have a longitudinal treatment arm. And in that longitudinal treatment arm, we have 33 folks with catatonia. So biological sex distributions, about 50-50 almost. The average age of folks that we have are 16 years. The minimum is 5, maximum is 31. And the vast majority of our patients with catatonia have a diagnosis of profound autism. And then this would be intellectual disability disorder next, childhood schizophrenia next, and then autism without intellectual disability. We actually have 3 cases of seronegative autoimmune encephalitis, which basically means that they have autoimmune encephalitis with an antibody that can't be identified. And they're usually from racial or ethnic groups that are generally excluded from clinical research, Black folks, folks of Asian heritage that are not included in antibody research to identify encephalitis. And then we've also had a young man who has who contracted influenza and developed catatonia. He's doing really well. So these are the presenting symptoms. And again, I want you to think about SYNGAP in terms of challenging behaviors that have been described in the literature. So there's aggression is the primary symptom, 74 of 33. And again, some of these folks come in with more. Self-injury is 20 of 33, and then stupor is 18 of 33. And Jackie has given me permission to share. Her daughter Jaden is one of our patients, and she's our only patient with SYNGAP1 who has hyperactive catatonia. And I'll show you a graph that represents her treatment, and hopefully we'll be able to write up her case and sort of share with other folks that catatonia is something that should be considered. So these are the other genetic conditions. There's DeGeorge syndrome, 22q11, Down syndrome, trisomy 10, neurobeach invariant, Skaber, and Rett syndrome. And about 30% of our patients have been treated with ECT. And I'm really proud of this number here. So we've been able to significantly reduce admissions to inpatient psychiatric or inpatient medical admissions. So there's not really any good data that says like, hey, this is how often people with catatonia are readmitted. But there's a huge study that looked at childhood psychosis, and I thought comparing it to that would be probably comparable. And the rate of readmission for childhood psychosis is about 40% in a calendar year. We've been around for 2 years, and we've only had 18% of our patients get admitted. So I'm going to share with you some of our really research I'm super proud of and really happy to work with a lot of amazing folks. So all of our research that's currently under review or has been published includes only kids. And we're going to publish on catatonia treatment in adults with neurodevelopmental conditions in the very near future. We're just continuing to collect data there. And so the next few tables and graphs I'm going to show you, they're currently under review with the Frontiers of Child and Adolescent Psychiatry. It's also a continuation of this brief report where we characterized hyperactive catatonia and profound autism that we saw at the Children's Hospital. And every patient that we'll talk about was treated with at least a benzodiazepine, and that's important to consider when you look at our tables here in a moment. So this is from our study. This is not from the clinic itself. And this also includes folks that are not in our clinic that we weren't able to follow. And so we had 60% biologically male, 40% biologically female. The mean age was 13 and a half. And these are our ethnicity distributions. And something I'll point out to you is that I know in the SYNGAP community, there's a lot of concerns around like psychiatric medications there's a lot of polypharmacy, there's a lot of medications that are being used. And in this particular study, we found that 24 of the 31 folks had previously been on a psychiatric medication. The range of that was we have kids that have been on up to 12 to 13 psychiatric medications without clinical improvement. And I think our mean was 6 or 7 medication trials. And then 26 of the 31 had a comorbid neurodevelopmental diagnosis. And I think that's really important to highlight as well. A little bit of it is selection bias because we're at Vanderbilt Children's Hospital. And so we're oftentimes going to see folks with really significant neurodevelopmental conditions. And so there's a little bit of selection bias there, but I think it's an important distinction. And then 10 of the 31 had history of seizures, which we've talked about. There's certainly a connection between epilepsy and catatonia. So again, to highlight the challenges around dosing. So what we've seen is that folks with catatonia really need high dose benzodiazepines to have clinical response. And in this particular study, we found that the mean amount of Klonopin in a single day that someone needed for stabilization, a child, was 7 milligrams. And for diazepam, which we used in 4 of the 31 cases, it was 160 milligrams. And to give you a point of reference, that's a mean of about 14 to 28 milligrams of lorazepam, that's the mean. It's a lot. And it's an issue of comfort. It's an issue of communicating with families about the fact that we need high doses. And it's also a comfort with folks in the community. So if we have people that come into children's or come into the psychiatric hospital, they need high doses of benzodiazepines, and we're trying to find them an outpatient provider, it can oftentimes be really challenging to find an outpatient provider who's comfortable with that amount of benzodiazepine. And then these are the other medications that were represented. We discussed these already, but memantine was used in 12 of 31, amantadine in 1, valproic acid in 4 of the 31 kids, and then trileptal, abilify, and clozapine. So this is just to show you that we assessed all of these kids by 4 different measures. So we used the Bush-Francis Catatonia rating scale, we used the Cantor severity scale, and the Cantor, this actually should say Cantor examination, sorry about that. And all 3 of these showed, what this means is that they all had statistically significant reductions in their symptom profile. And to make sure that we weren't just sort of looking at the numbers in a way that was like, no, look at it, everything's going well. We had 4 of our authors go back and review all the charts and assign a number, something called the CGI-I. So basically the CGI-I is a scale of 1 to 7. 1 and 2 are considered significant improvements. 3 is minor improvement. 4 is no improvement. And then numbers below 4 are considered worsening. And so we had 4 of our authors go back, look at the charts, and then assign a number of clinical improvement. So the probability of scoring a 2 or less, so again, statistically significant improvement, was 0.86. And then 98% of the patients that we saw scored a 3 or less. And that was across 4 authors, and we were blinded to the results of the other authors. And this is a really interesting table. So everybody was on a benzodiazepine, either clonazepam or diazepam. And so 10 of them only needed benzos. And then 18 of them needed a benzodiazepine plus an additional medication, usually a glutamate antagonist like memantine or amantadine. And then for folks that needed benzo plus 2, it was efficacy 2. This is a little bit confusing sort of distinction here. It was 2 patients that needed more. And this is just a box and whiskers plot to show you what we already talked about. So this is the Bush-Francis Catatonia rating scale. This is when we met folks. And this is a little challenging too. And I'll share Jaden's clinical improvements with you all. And this is an important distinction when you look at that chart too, is that folks with autism or neurodevelopmental condition are going to have an elevated Bush-Francis Catatonia rating scale all the time, because there's a lot of symptom crossover between catatonia and autism or catatonia and neurodevelopmental conditions. And so what we're looking for is, are we getting back to the number where that is where they live? That's their baseline number, as opposed to looking at it to go completely to 0, because these are not designed to go to 0 for folks with neurodevelopmental conditions. And so when I say baseline here too, I mean like when we encountered the patient with catatonia. And so the average score was close to 20 here, and then at stabilization, the average score is a 5. And this goes to 68 total. The Cantor severity goes to 144. The average was a little above 35 for when we met folks with catatonia. And then the score at stabilization was a little below 10. And then the Cantor exam is out of 12. And again, when we met folks, there was a really big outlier here, but generally it was 3. And then 0 was the average for the exam. So this is interesting stuff, but what does it have to do with SYNGAP? Why am I talking to you guys? So SYNGAP1 mutations likely result in complications due to the brain being too excitable or the brain being too plastic. And evidence for that includes the fact that SYNGAP1 folks have a lot of symptoms consistent with autism, which we have already sort of established is the prevailing theory behind autism is that it's secondary to the brain being too excitable or too plastic. And then early onset epilepsy is another additional sort of like evidence for the fact that the brain is probably too excitable, intellectual disability, and ataxia. And similar to SYNGAP, it's been hypothesized that catatonia is due to reduced inhibitory tone in the brain. And while there's no published reports of SYNGAP, there are many other neurodevelopmental conditions. And as we talked about, Jaden will likely be the first patient that's described to experience hyperactive catatonia. And so just to go back to the slide that we discussed at the beginning, what does this have to do with SYNGAP? So again, published reports of challenging behaviors in SYNGAP really cover a lot of symptoms that are consistent with catatonia and autism: affective instability, oppositionality, ataxia, recurrent self-injury. But this is an area of untapped research in SYNGAP that I think is, certainly a promising one. So with Jackie's permission, this is Jaden's sort of clinical profile. So these are the number of visits that where I saw Jaden, and I met her, and she actually was not having catatonic symptoms at the time I met her. She established care. Jackie and Jaden were looking for a psychiatrist who treated folks with neurodevelopmental conditions. And then at our third appointment, she started developing symptoms of catatonia here. And Jackie did an amazing job describing like Jaden's history of having these surges of challenging behaviors that would dissipate over time, which fits the bill for sort of a recurrent catatonia picture. And we slowly went up on clonazepam. And again, I'll kind of reiterate why clonazepam over lorazepam. So these are the blue graphs here where you can see the dose. And then we started memantine as well. And so as we went up, Jaden's symptoms improved, and she was doing really, really well here. And then unfortunately had another bump in her symptoms. And so we've increased her clonazepam some more. And her score actually at our appointment yesterday is back down here to 28, where she had her period of greatest stabilization. And I only used the Canner severity scale because a lot of our appointments were over telemedicine, and it was difficult for me to do. I can watch her and then I can have Jackie do some of the examination, but I want to make sure I was giving you guys fresh data. And so this is just the severity scale. So just some additional thoughts. Previous work in autism has suggested that cortical hyperplasticity and hyperexcitability may play a role in symptom development. But what that means is that you have a brain that rapidly acclimates. So plasticity means that the brain can rapidly acclimate to what's around it, or there's actually this developmental level of plasticity where kids are learning things really quickly, and so their brain needs to change really quickly. And so we actually think that there's probably a developmentally expected degree of hyperplasticity in kids, which might make longer acting medications more appropriate if children are experiencing catatonia, but also if folks with autism are experiencing catatonia. And so again, this is possibly a similar issue in SYNGAP, based on what we know about SYNGAP sort of neurobiology. And then hyperplastic and hyperexcitable brain may rapidly acclimate to new medications introduced to the cortex, which may contribute to medication resistance, which I know has been described in SYNGAP literature, and of course with like parent groups. And this would explain why lorazepam is not as effective as we would hope that it would be when you're treating someone who has like schizophrenia, but otherwise has neurotypical development. And it offers a possible explanation for that. So some big take-home points. Catatonia is an identifiable and treatable condition that commonly occurs in profound autism and other neurodevelopmental conditions. A lack of familiarity with the condition, assessment measures, and discomfort with high-dose medications and or ECT likely leads to under-recognition and treatment. For other providers, like when I'm communicating with a pediatrician or a family medicine doc, or really anybody outside of psychiatry, and even some folks in psychiatry, it's a little weird to talk about catatonia because you diagnose catatonia based on your physical examination. And despite us describing catatonia in the 1800s, we don't have a biomarker for catatonia. Like there's not a lab we can draw that says this is definitely what this is. And so there's reliance entirely on the physical examination to guide treatment. And honestly, in modern medicine, it's kind of odd. Like we have a lot of neuroimaging, we have MRI, like we've had these huge advancements, but catatonia is one of these things that still is like, okay, we don't have anything that we can definitively say like, this is the biomarker. So there's a lot of reliance on clinician opinion, clinician examination to guide treatment. And given the high degree of connection between catatonia and cortical excitability, it's likely that individuals with SYNGAP1 have likely experienced catatonia. Certainly Jaden has experienced hyperactive catatonia, has responded well. And while this hasn't been addressed in the literature, we're working on it. There are probably like more than 100 references. I'm happy to provide them on request. And there also some are included in the slide deck as well. And these are my acknowledgements. I really want to thank Jackie and Jaden for working with me. It's been a pleasure to have them in clinic. And I also want to thank all of our other patients and families, as well as the Bressler Clinic where I trained, and then the Men Clinic where I currently am. I'm happy to take any questions. And I'll leave the slides up if there are questions that are specific to slides. We can go back to those.
Oh, that was so good. Okay, let me see. I think, Olga, you could just read it if you want, your question, if you're here.
I am here. Yes,
Okay.
I was curious. I had seen on one of the slides that you had mentioned, excuse me, TMS. What is the difference between ECT and TMS? And is TMS something that is considered as a treatment for catatonia or neurodevelopmental ASD?
It's a great question. So ECT is a much more invasive procedure, but it has much more evidence for its use in catatonia and irritability and self-injury and autism. ECT is folks go to receive ECT, they are put under generalized anesthesia and their muscles are paralyzed and a seizure is induced. And so really you just see a seizure occurring on the EEG and some light muscle fasciculations. And the time course is shorter in ECT than it usually is in TMS. TMS is non-invasive. We use a big magnet basically to inhibit or stimulate a certain part of the brain. And part of our research is looking at, can we use TMS to develop biomarkers for catatonia and autism? And can we use TMS to treat catatonia and autism, or potentially improve verbal ability for folks that have reduced verbal ability with autism? And so they're both neuromodulation in that they both use electric currents to change the cortex. But TMS is much more targeted and doesn't require generalized anesthesia, but does require people to come like every 5 days a week for 6 weeks to receive treatment. And there's not definitive literature that it helps with catatonia yet. Whereas ECT is a little bit shorter in time course and has a lot more evidence for treatment of catatonia.
Okay, thank you. And so ECT is like a last resort after medications don't work. Is that correct?
Yeah, I think that we probably don't use it early enough. It is a really, really effective treatment in catatonia, but yes, generally and totally understandably, what parents want to do is we'll try meds and then we'll do ECT, which makes perfect sense to me. Like if it were my child, I would totally agree. Like you don't want to have to undergo an invasive procedure when you can just take medication to improve symptoms. Makes perfect sense. So generally that ends up being the steps that we take, sort of like when we are working in collaboration with families.
Okay. A lot of our kiddos, and I know I'm jumping in with more questions that aren't on the actual chat, but
that's okay. That's what you get for having the
being in control, right?
Right.
A lot of our kiddos, end up on risperidone, which I think for us that certainly helped, but I think we still have a long ways to go in terms of improving things. And I'm just wondering what we could take to our neurologists, psychiatrists to kind of maybe heighten their awareness on possible catatonia, because I certainly see seeing my son some of the symptoms that you've referred to.
Yeah, I think that giving them literature on it, we're trying to publish as quickly as we can to try to bring awareness and do talks like this for families, but also for psychiatrists to say, hey, look, this is something worthy of consideration. Risperidone and aripiprazole certainly have their place. They're the only 2 FDA approved medications for autism ever. And they're only approved for irritability in autism. There's no FDA approved treatments for the sort of core features of autism, social emotional relatedness difficulties and restricted interest repetitive behaviors. And so, we've done psychopharmacology research in autism for decades now, we've had a lot of failed clinical trials, and there's a lot of reasons for that. I think that part of it is that there's a lot of heterogeneity in terms of what's causing autism symptoms. Like in SYNGAP, the autistic symptoms are probably due to SYNGAP, right? Like it's probably due to the genetic alteration. And the same is true in Phelan-McDermott syndrome. But for folks that have autism without an identifiable genetic abnormality, do they have one that we haven't caught? Do they have one that we don't know how to characterize? Or do they just not have one? And so I think part of the challenge there, and one of the reasons why catatonia in particular is interesting to me from a clinical perspective and research perspective, is it's something that we've described as happening across a myriad of different neurodevelopmental conditions, and it's something we can treat. And so what I would say is, if you're talking to your neurologist or your provider, saying like, we've seen this behavior change over the past couple months or something, is this something that would be on the differential of things we could consider for why this is happening? And you're more than welcome to give them my contact info, and I can share some of our research and data with them too. But I think that a lot of times when you're talking to providers, bringing up catatonia if there is an acute worsening, I think is a really key component, because catatonia really is like, catatonia is not a, we don't think catatonia is a chronic condition. We think catatonia is something that's like, we have an acute behavior change that we need to treat. And for Jaden, I think that made a lot of sense, where like Jackie is, super diligent around describing Jaden's symptoms and saying like, look, Jaden has these flares of really significant behaviors that last X amount of time, and then she's back to herself. Like that sort of episodic nature, again, adds more evidence to the fact that it's hyperactive catatonia.
Yeah, they're a trigger. Well, I feel like there's a trigger and it just comes out of nowhere, and then you start to become in tune about when maybe it's about to happen.
Yeah.
And then, things are back to normal. But the hyperplasticity, and I know in medical terms that probably means something different, but my kid as a teen anxiety will not go anywhere. I mean, except school, very limited places. He used to go everywhere when he was little, sometimes with behaviors, but now it's like major aggression towards us if we're trying to ask him to get out of the car and go. And we don't know if that's just his preferred, what he wants to do, doesn't want to do. Is it, he can't handle, I mean, and that's a whole other aspect of behavior, but the aggression, boys, if we could control that for SYNGAP parents, that would be huge.
Yeah, and I think that's, one of the reasons that I was so excited to talk to you guys is that I sort of the hill that I kind of die on sometimes is that aggression doesn't happen without cause, right? Like whether it's external stressors, whether it's catatonia, whether it's mood, like we need to push the science and literature in a way where we're thinking about that of like, how do we identify aggression? How do we treat aggression? How do we get things improved? So yeah, and I can definitely appreciate that if there was like even a 10% improvement in aggression on a day-to-day basis, that would be, I would expect life altering for a family.
Yes, absolutely. Thank you. I know we have some more questions in the Q&A. Jackie and Lauren, did you want to take those?
Yeah,
Yeah,
sure.
I can read. Go ahead, Jackie. I'll let you go. Yeah.
I just wanted to thank you for doing this because it's so important. And, we struggled with this a long time before you came to Vanderbilt and before we had access to a doctor with your caliber understanding of this. And a lot of the things you described, especially during the period of malignant catatonia, that was probably the most terrifying time throughout Jaden's life for us, and she was well documented and she was well cared for by many specialists under Vanderbilt's care. We ran every test we could think of. We were, the blood pressure was through the roof, and heart rate and respirations, and we could barely get 500 calories in her a day, and yet she was destroying the house in super high aggressive episodes, very dangerous to her and us, her providers. And despite rheumatology and complex care and all of these physicians trying to figure this out, none of us had an answer. So what would you say to other parents who, are in that kind of situation where maybe they're not going to be coming into Vanderbilt with a Dr. Smith there? Maybe they're going to their ER at their rural hospital or somewhere else that this is completely unknown to them. How can they get care, especially those high level of benzodiazepines to kind of stabilize an acute episode without the parent sounding crazy,
Sure. A tall request there, Jackie. I think that I honestly think that in communities where there's not providers that are comfortable with high dose benzodiazepines, looking for ECT treatment is probably the best thing they can do, because a lot of ECT providers are going to recognize malignant catatonia because they treat malignant catatonia in a different setting, right? Like before I met you all, I treated malignant catatonia for a kiddo with encephalitis at Children's, right? And so a lot of these ECT providers are going to have seen medically ill folks with malignant catatonia. And if you walk in and you say like, hey, vital signs are through the roof, you know, they're not eating, they're not drinking, we feel like this is malignant catatonia, a lot of ECT providers are going to be able to recognize that. Part of the challenge there, again, is that ECT is a really invasive procedure. It's heavily stigmatized, and there's not enough providers in the country to be able to accommodate those needs. And so what I would say is, you know, try to use these groups, try to, you know, have folks to reach out to, or even say like, have you heard of this? Would you be willing to look into this for me? And then even in an ER setting, I think it would be totally reasonable to say, hey, can you give my kid 2 milligrams of Ativan and see if they get better? You know, that's a pretty low bar to say like, could we try this pretty, you know, innocuous medication that you use all the time to see if we can get significant benefit? And so that would be, it's a tough, I totally recognize it's a tough thing. I get a lot of emails from folks with kids with Phelan-McDermott, with DeGeorge, where they're saying like, we don't have anybody in our community that recognizes what's going on. And so we try to hook them up with people and then do some education around that. And so I'm always happy to try to facilitate some of those things, but I think those would be kind of low-hanging fruit to go for.
We have some questions in the chat box from Alicia Talbot. Says Down syndrome dysregulation disorder and or PANS, PANDAS, these would potentially respond with these treatments as well.
Down syndrome disintegrated disorder, yes. There's pretty robust literature and evidence looking at Down syndrome disintegrated disorder as a phenotype or like a subtype of catatonia. It's in Downs, there's like a more chronic onset, and it's oftentimes associated with comorbid gastrointestinal disease and autoimmune conditions. And so, yes, ECT can definitely help with that, as can high-dose benzodiazepines. It's tricky in Down syndrome, though, because folks with Downs, because they have the third 21st chromosome, are at a significantly elevated risk for Alzheimer's dementia already. And so if they're getting high-dose benzodiazepines, it's likely that that's going to exacerbate the risk. But to my mind, it's control the catatonia first, you know, make sure that we're doing well right now. Because again, it acts like seizures, and we have no idea what the long-term cognitive outcomes are for somebody who has untreated catatonia. But I would imagine you want to treat the catatonia first and then can worry about the second part later. And then PANS and PANDAS is it's a little bit complicated of an issue, because there's not a lot of, so the short answer is no, is that PANS and PANDAS generally, those are treated in a similar sort of way as refractory OCD, which ECT and high-dose benzodiazepines have not been utilized for with like good success.
Corey Basin asks, what next steps do you recommend for SYNGAP1 parents?
I think, you know, if you're worried about catatonia for your kiddo and you have a psychiatrist that you see, I think bringing it up with them and showing them the most current literature is a reasonable thing to do. You know, we learn a ton from our patients and their families, and, you know, we should always be sort of open to listening, like, hey, I've done my research. Like my, you know, phrase is always like, you're the expert of your own child, right? Like, you know, when something is off, or you know, when something's different, and that collaboration with families, I think, is really important. And so if you're worried about it and you think it might be a component or condition of what's going on with your child, I would definitely, you know, bring the literature, bring it up with your psychiatrist.
Minnie Zhao asked a good question. I've asked you this before myself. So as far as ECT protocols, do they have to do ECT for a specific period of time? Does catatonic conditions come back over time and people have to get a series of ECT again? How long does that go on?
We're still trying to figure that out. In the paper that we put out last year, where we looked at 10 years of data, some folks responded and never had to have maintenance treatment. So the classic traditional way that folks do it is they come in, they get 3 ECT treatments a week for 4 weeks, and then they start spacing them out, where they'll get 1 a week and then 1 every other week and then 1 monthly, and then eventually stop. And then for the majority of folks, that does the trick, where it's like, okay, you know, we don't need to do continuous maintenance treatment. We have had folks with really severe cases where they've come in weekly for a long time for control, for symptom control. And so it's very sort of person to person dependent. But for those folks that come in weekly, it's usually a life-saving intervention, where without it, they are not eating, or they're having really significant vital sign instability and whatnot.
Yeah, I specifically like that you pointed out that genetic disorders are often excluded from the research. And even when we are researching conditions such as catatonia, I think that that's really affecting the ability for us to get treatments. And so it's definitely something for us to consider.
Yeah, absolutely. Well, I really appreciate you guys inviting me. This is great. And I'm happy to come back in the future or talk more about catatonia.
Absolutely.
Thank you
Thank
very
you, Dr.
much.
Smith. This was very informative.
Of course,
Really.
yeah. It was a pleasure.
Okay,
All right.
take care.
Take care. Bye.
Bye.